Hi, everyone. Welcome to our discussion of hospital overuse during the COVID pandemic. I'm Vikas Sani, president of the Lown Institute.
And I'm Shannon Brownlee, special advisor to the president at the Lown Institute. We're really glad that you all could be here for this important conversation.
So this is our fourth event of the year, highlighting various metrics of the Lown Hospitals Index. That's our groundbreaking program that's the first to measure the social responsibility in the hospital sector. We created this ranking because we believe a radically better healthcare system is possible, but only if we have the right data to help guide us there. The Lown Hospital Index includes metrics that haven't been used before, like ratio inclusivity, cost efficiency, and avoiding overuse, which is the one we'll be talking about today. In just a minute, I'll bring on Kelsey Chalmers, who's manager of data research at the Lown Institute, to discuss the findings we have on hospital overuse during the COVID pandemic. But first, I want to explain a little bit on our perspective and why we think this matters. So overuse or low value care refers to medical services that offer little or no clinical benefit, or more likely to harm rather than benefit patients. Now, our late founder, Dr. Bernard Lown, was an early advocate of avoiding overuse whenever possible. In fact, his motto and what he taught us was to do as much as possible for the patient and as little as possible to the patient. So when I trained with him, it was not unusual to have second opinion patients come to us. People would come on a Monday with their bypass surgery scheduled for the Thursday or Friday and wanting to know, is this a good idea? And, out of several hundred in a series we published, it was quite amazing at the survival rates. We would recommend the vast majority of people did not need surgery. And many of those who had their OR date and canceled it lived 10, 20 years, came back regularly and enjoyed telling that tale. So that was sort of an illustration of at least my early understanding of how alternative ways of thinking about this can really matter for patients.
So if you've been following the Lown Institute, you probably already know that overuse is important it's sort of core to some of the work that we've done in the past, and it's prevalent and wasteful. But even more important, overuse exposes patients to harms they never would have experienced if they had not received that unnecessary test, procedure, or hospitalization. So in a study that we published in JAMA Health Forum last summer, we found that about 1 in 100 low-value procedures in hospitals resulted in a hospital-acquired infection or some other patient safety event in the hospital. And these events led to patients spending an additional 4,200 days in the hospital each year. And this was for a very small number of the possible procedures and tests that are overused. So there's another common type of harm from overuse, which is the follow-up tests and procedures that happen as the result of an individual unnecessary test. And these are known as cascade events. So cardiologist Steve Nissen from the Cleveland Clinic published a very serious example of this. But the patient came in with chest pain, and she said, it's probably just because I pulled a muscle, but she was worked up as if she were having a heart attack. So first she has a stress test, and that's got some little anomaly. And then she has a heart CT, and that might have some little anomaly. And then she has a catheterization, and that leads to one of the rare but very serious side effects of this procedure, a dissection or a tear in her cardiac arteries. She then develops heart failure and has to have heart transplant. So cascade events are incredibly common. In a 2019 survey of physicians, more than half said that their patients were harmed by care cascades at least several times a year.
So over the past decade, there have been efforts to raise awareness about overuse, to educate clinicians to avoid these services, to develop new payment models to move away from fee-for-service. But on a national scale, the rate of overuse hasn't really budged. So when COVID hit the US in 2020 and hospitals had to stop all elective procedures suddenly, many in the research field on overuse saw that a bit of a silver lining in the pandemic, or at least an opportunity to think about how stopping unnecessary things might happen and whether or not that might continue. Many hope that the shutdown might force doctors to prioritize high-value care more than low-value care, and that once hospitals open back up, those priorities might stay in place. So, and with the continued risk of COVID and shortages of resources, you might have thought that socially responsible hospitals wouldn't be bringing patients back in, especially older patients who are more vulnerable during the pandemic, to do procedures that, are of uncertain or doubtful clinical benefit.
So what actually happened to overuse in 2020 during the pandemic? To find out, we used Medicare claims to compare the rate of overuse of common low-value procedures or services in 2019 to overuse rates in 2020. So we have with us today Dr. Kelsey Chalmers, Manager of Data Research at the Lown Institute. Before joining the Lown Institute, Kelsey worked as a health policy researcher at the University of Sydney in Australia, where she also received her PhD in public health. So Kelsey's research interest has centered around healthcare overuse and equity. So Kelsey, welcome to your first Lown Index launch event. So can you walk us through the new research and some of our findings?
Yes, of course, Shannon. As well, thank you, Vikas and Shannon. Very happy to be here and really excited to present our findings on overuse in 2020. As far as we know, this is the first analysis of overuse rates during the COVID pandemic. So 2020 feels like a really long time ago. So let's take a moment to recall what was happening with COVID in that year. So COVID first hit the US and the Northeast in the middle of March 2020. Hospitalizations were high in this region, and there were a few months where there was a stay-at-home order and everything was shut down. Then in the summer, we had another COVID wave, mostly driven by cases in the South and the West. And then there was a lull in the early fall, but cases increased again in November and December, far beyond what they were earlier in the year. It definitely was a pretty crazy year. So we wanted to know what happened to overuse during both the initial shutdown period and the rest of the year. So to understand what happened to overuse in 2020, we answered three main research questions. Our first one was, what was the volume of low-value services in 2020 compared to 2019? And what was the rate of overuse? So to answer this, we used Medicare beneficiary claims from 2019 and 2020, and we included 10 services from the Lown Hospitals Index. Today, we're only going to look at results for surgical procedures in our index. These include coronary stents for stable heart disease, hysterectomy for benign disease, arthroscopic knee surgery, back surgeries, and more. You can see the full list of procedures and the criteria for overuse on our website. So this slide shows a quick refresher on how we measure overuse in the Lown Index. We first count how many surgeries were done, and then we find the proportion of those which were low value. So for example, our measure of coronary stent overuse shows how many of the stents a hospital placed were for patients with stable heart disease, which studies have shown provides no clinical benefit over medication alone. And for each of the procedures in this study, we counted the number of patients who got the procedure in both 2019 and 2020. We call that the volume of the procedure. Then we looked at how many patients got the procedure when they shouldn't have. That's the rate of overuse. And today we're going to show both the volumes and the rate of overuse in 2020 compared to 2019. So this first chart shows the volume of patients receiving any one of the procedures, regardless of whether the procedure was low value or not. The pink line in the background shows the national COVID cases from the chart we showed previously. So at the start of 2020, the volumes are pretty close to what they were in the previous year. Then from March and throughout the shutdown period, there was a dramatic drop. The volume of these procedures all dropped by more than 50% nationwide. After the shutdown period, however, many of these volumes were at or close to 2019 volumes for the remainder of the year. This next chart shows the volume of patients receiving low-value procedures. These are the ones that met our criteria for overuse, like stents for stable heart disease. You'll see that the number of low-value services also decreased a lot during the initial shutdown. After the shutdown, however, they bounced back up to within 90% of the 2019 numbers. So this chart just sums up the pattern that we saw in the previous two slides. It shows the rate of overuse, the proportion of procedures that were low value. We would expect these lines to be equal the whole year if there was no change in the proportion of patients who received a low value procedure. But we see that, at least in the few months of the shutdown period, the overuse rate did decrease, which means that fewer people were getting these procedures and a smaller proportion of these were inappropriate. However, after the shutdown period, the overuse rates went right back up to where they were in 2019. So just to sum up, we saw a decline in the volume of all procedures and a slightly larger decline in the volume of low-value procedures during the shutdown period. But after May 2020, both the total volumes and overuse rates went back to where they were in the previous year.
So Kelsey, what you're saying is that there was a decrease in the rate of overuse during the shutdown, but after that, it looks pretty much like business as usual, not only in the rate of overuse, but also in the total volume of procedures. Right?
Generally, yes. Yeah, we'll see some results in a few minutes that show the breakdown across some different states. But nationally, yes, it was pretty much back to business as usual after the shutdown.
Vikas, you have any thoughts?
Well, I guess, I'm curious, Kelsey, what you thought of these findings compared to what you thought or what others might have thought about what was going to happen to overuse in 2020, like ahead of the time.
I certainly expected the volume of procedures and patients to decrease in hospital during the shutdown. That was no surprise. It was a good thing to see that the rate of overuse dropped during the shutdown as well. But it did surprise me that the rates returned so quickly after the shutdown.
Yeah, I expected the same thing.
Well,
that
they returned quickly because, I was going to say they returned back, but part of the issue here is how uneven the pandemic was throughout the country. So when you have this sort of administrative thing of shutdown, you get this very generalized event and effect. And so we see that. After that, it was more, kind of variable based on where you were and what you were doing. And so in theory, you might say, well, it's not a surprise to see things bounce back because at any given moment, some places might have been hard hit, but much of the country wasn't. And therefore, maybe much of the country would have been back to business as usual. What do you think?
Yes, I would agree with that. We'll see a slide later on where we know in the shutdown period, a lot of states actually had close to zero COVID cases. And so these hospitals were sort of empty during this time. Of course, they went later in the year, but they also had to decrease their volumes during this period.
Yeah.
Yeah, but I'm going to be the grumpy person here and say, if ever there was a moment when you would hope that awareness of overuse would have sort of taken hold, that people would be concerned about it, physicians would be concerned about it, maybe patients are starting to get concerned about it, you would think that would be the moment during COVID when everybody would say, now, wait a minute, is this procedure really necessary? Do I really want to be in the hospital at this time when there may be low COVID, but there's some? Or physicians, do I really want to bring my patient into the hospital when a COVID wave could hit at any moment? So I guess I was a little bit surprised by the fact that there wasn't this kind of carpe diem, take the opportunity to start really reducing overuse, except during the shutdown period.
Yeah, except that assumes that a lot of low value care is discretionary, available to conscious decision making, and in that sense, amenable to saying, you don't really need this. I mean, I was going to do it, but you don't really need it. And now with the damn pandemic, you absolutely don't need it. I don't think that's how it works. I think, most of the time, both the doctor and the patient feel like this is really going to help, and so in that context, you need, the countervailing force has to be fairly large. And I think what we're going to discuss and what we'll see is that countervailing force, when it was a shutdown, was one thing. When that countervailing force was a virus in the community, it was something very different.
Yeah. And, what it says to me is that I have a particular interest in the sort of lack of awareness of the potential for unnecessary harm or preventable harm, as it's now called, from overuse. And so there's really a lack of attention to the possibility of preventable harm from a procedure that is iffy. And while I agree with you, Vikas, that physicians are not thinking that way clearly, I wish they would, because of the unnecessary harm piece. If you don't have an unnecessary procedure, it can't cause if you don't deliver this, it can't cause your patient harm.
Yep.
So,
go
ahead.
No, you.
Well, so we have other research questions and findings to talk about some specific procedures that I think are actually going to illuminate some of what we're talking about here. But we have some really great questions from the audience. So thanks for using the Q&A to ask your questions. So we have a question from Walt Sokek. Oh, yes, I hope I'm pronouncing your name right, but I bet I'm not. Do you believe this trend in use rate and volume can be extrapolated to all payers and age groups? Great question. I'm going to punt that to Vikas and Kelsey.
You want to take a shot at it, Kelsey?
I mean, I'm inclined to say yes. I do believe it could be extrapolated, especially when we consider that. So our numbers are for the over 65 population, which you think would be the one group that you would want to keep out of hospitals during this time. So who knows, maybe the results could be quite different to a younger cohort.
Yeah, and I would add to that. I agree that I think it can be extrapolated. I think the reason I think it can be extrapolated is actually what we're seeing are just, something that's not very complicated to describe. There was an official shutdown. There was a big drop in volume. Shutdown officially ended. Volume returned. Full stop. There's a lot of nuance in what we're seeing. It was just like up, and now it's back. So in that sense, I expect that dynamic would be present for all payers and all age groups.
And let's remember, there was no vaccine. And these are all over 65 patients, people who are the most vulnerable to COVID. So I am surprised by the absolute return to the total volume of services after the shutdown. So we have another question from Chris Elliott. Do we know if there is a difference in overuse by hospital employed specialists versus independent specialists? That's a really interesting question. And I'm going to ask Kelsey to answer that one.
It is a really interesting question. We do not know at this time because we have not done that analysis.
Can we do that with the Medicare data?
We could.
Good. That'd be interesting.
Yeah. Let's keep going. So the next set of research questions, Kelsey, back to you. New slides.
Great. So here's the second research question. As we mentioned before, COVID-19 cases were high across the US in 2020 and much higher than during the shutdown period. So we wanted to know whether there was a relationship between overuse of these procedures and the COVID-19 case incidence. To answer this question, we first found the weekly state COVID incidence in 2020 using data from the CDC. We then decided any states with an incident greater than 175 cases per 100,000 persons were in a high COVID period, and anything lower than this was in a low COVID period. This chart shows the overuse rates of procedures we measured in states during periods of low COVID-19 cases. The vertical axis just shows the overuse rate compared to the same time period in 2019. A ratio of 1 means the rate of overuse was the same in 2020 as it was in 2019. So for all of these procedures, the rate of overuse was pretty close to the 2019 rate during these low COVID-19 case periods. Now, with these orange bars, we've added in the overuse rate ratios during periods of high COVID-19 cases. So for most procedures, the overuse rates did not change much when COVID-19 cases increased. The overuse rate for coronary stents actually increased slightly during periods of high COVID-19 cases. The exceptions we have are hysterectomy and knee arthroscopy, which appear to have overuse rates that actually are sensitive to COVID-19 cases. Particularly for knee arthroscopy, the rate of overuse declined from a little over 80% to about 70% of the 2019 rate. It's also worth noting that for coronary stents and vertebroplasty, the rate of overuse was basically the same as the rate in 2019 during periods of high COVID-19 cases. You can see that the orange bars for these procedures are very close to 1 on the y-axis. That means they're near the 2019 rate. So for coronary stents, the orange bar is actually a little bit over the 1. So our key takeaways from this. For most procedures, the overuse rate ratio during periods of high COVID-19 cases weren't much lower than in periods of low COVID-19 cases. And some procedures had overuse rates similar to 2019, no matter what the COVID-19 incidence was.
So, we've already made the point that this is Medicare patients. So this is, pre-vaccine. So this is a group that were, more vulnerable. And so the question is, what is it that was there or was not there during the high COVID period, high incidence period? So no shutdown, but a high period in that locality. What was present or what was not present that actually led to really no kind of alteration in patterns? And I don't think we're going to have an answer for that. I think we can speculate on it because it's going to be all the various drivers of low value care in general that people have been talking about and elucidating for over a decade now.
I want to point out one thing about vertebroplasty and coronary stents. These are two procedures that have been researched very closely and carefully. There have been, I believe, 4 sham surgery trials of you're in the video. 4 sham surgery trials of vertebroplasty, which means that that vertebroplasty for back pain from arthritis, fractures in the spine was tested against a fake surgery. And in all 4, it showed that vertebroplasty was no better than doing a sham surgery. So this is a really clearly researched procedure. And coronary stents, the same thing. There's been an abundance of research. It is very clear, and it should be very clear to physicians what the data say about the effectiveness of these procedures and when they should be used and when they shouldn't. So Vikas, what's going on here? Why are physicians still doing those 2 in particular?
Well, I mean, look, it is deeply embedded in the culture. There's a sense of, how you interpret the data, when the data is actually generated. So in the case of, coronary angioplasty and stents. Look, the first balloon angioplasty was way back in the early 80s, Andreas Brunswick, and then, the stents came in after that later in the decade, and then everything took off. But the real large randomized clinical trials, took 20 years to actually get conducted. And so by that point, it's deeply baked into the cake of, practice, assumptions. I mean, the number of times I've had these long-winded conversations and arguments about this, is too many to count. So really, it's a systemic problem we have. The nature of the evidence, the timing of the evidence, as well as the relative incentives and disincentives. It's not so much that there's an incentive to do these financially, which is what a lot of healthcare policy people like to focus on, especially economists. Yeah, I mean, there's an element of that. It's more that there's no disincentive, that it's an easier path. It's a fast path. It's biologically plausible, right? I think it's Steve Nissen likes to say, the road to hell is paved with biologic plausibility. So when it's plausible and all these things happen. So in this instance, I think it's really the inertia of this huge ongoing contemporary style of practice against the virus. And I think what we're seeing is that the virus on its own didn't do that. Now, there could easily be some mitigating elements there. And we can talk about that. So for example, I think we all remember well that, in the early days, the really early days, we didn't think there was going to be a pandemic. It was just going to stay over there. How did that work out? But really, in the early days, we had no plan for PPE. We hadn't, we didn't have a vaccine on the horizon. Everybody was scrambling. Hospitals were scrambling to try and figure out what to do. So it could be that our data is, to put a charitable spin on this, that our data shows that during the shutdown, everybody learned how to operate in these conditions. Mm-hmm. And therefore, it's not that the rising rates of the virus, by themselves, would have been expected to change things. If we know how to do things, now we can proceed with business as usual, but with a whole bunch of other factors in place, which were in place clearly. I mean, you had to mask up to get into the hospital. You had to, you had the hand sanitizers, all that kind of stuff. So it's conceivable that that would be at least the surface explanation for why we're back to business as usual. It doesn't address the deeper questions, of course.
Yep. So let's flip the procedure question and sort of differences among the procedures and look at, so hysterectomy and knee arthroscopy actually did go down. And I think hysterectomy actually provides some really interesting insights here, because the criteria for whether or not a hysterectomy is overuse or not has to do whether or not cancer is present. So hysterectomies have sort of historically been done for all sorts of reasons, including, heavy bleeding during menopause, which generally resolves by itself. But also a hysterectomy is necessary for uterine cancer. And so it's really interesting that the rate of overuse for hysterectomy did go down and stayed down, possibly, and tell me I'm crazy, but possibly because physicians did clearly recognize that difference. They really know the difference between one that you need to do for cancer versus one that is just, quote, elective. And the number of elective procedures probably went down. Now, I don't think we were able to parse out precisely in this round of research which ones were for cancer and which ones were purely elective.
I'm not sure what you're saying. I mean, what we're measuring are the elective ones, but I think you're absolutely right about that. That in the case of hysterectomy, a lot of the indications for non-malignant hysterectomy. Remember, this is Medicare. It's postmenopausal women, so we're not talking about functional bleeding or any of that. So a lot of those indications are softer, if you will. It's not necessarily life and death. It may have to do with pelvic prolapse. It may have to do with a range of things, uterine prolapse, sorry, may have to do with a range of things that it is easier for both parties to say, you know what? This is a nuisance, but I'll live with this rather than risk COVID. So it's hard to tease out how much of that might have been on the doctor's side or the patient's side or both. But it does illustrate that here's one where there's a lot of discretion. And that's probably true for a lot of, arthritic knees. Like, you know what? I'm not playing tennis anyway. We're all locked down. So I'll wait. So that's part of it.
So I believe you have more research questions, Kelsey.
I do, if we want to move on.
Yeah. Oh, I see a question from the audience.
Oh, good.
Which is there a way to see how many patients getting unnecessary surgeries had a positive COVID test in days following the procedure in question? I have to think about that. We have access to Medicare data. We don't have access to test results.
Right.
So that test result would have had to translate into a diagnostic code being slapped on that chart. And the problem, and Kelsey, you'll know this, the problem is going to be, we're not going to know what day that diagnosis was slapped on the chart. And if we know that it happened, it's very hard to know. Was that person infected before they walked in and they converted? 24, 48, 72 hours, it's very fraught to figure that out, though. It would be very interesting, wouldn't it?
Yeah, we did a little bit of digging into this question because we sort of had the same thought. And by increasing, just looking at patients that had been in the hospital for at least a week or 2 weeks, you could sort of tease out those numbers a little bit, but it was actually quite small. And before we could really finish the analysis, there was another study that I think got referenced in the Washington Post at some point about the number of patients that got COVID while they were in hospital, using a different data set than what we had access to.
Yeah.
So those numbers
the people who got
exist.
COVID were the doctors and nurses.
Patients.
We didn't know that at the time.
Yeah. All right. So we have a final research question. Let's get into it.
Great. So for our final research question, we wanted to investigate the geographic variation of these results. So to do this, we again use similar methods to find the overuse rate of each state during each COVID-19 period. We compared these ratios against the mean 7-day COVID-19 incidence rate of the state. So here are the state overuse rate ratios during the shutdown period. And each of these triangles represent a US state. So the horizontal axis shows the average COVID-19 case incidence during the shutdown period. The further to the right the point is, the more cases there are in the state. And the vertical axis shows the overuse rate ratio. Again, a ratio of 1 just means that the 2020 rate was the same as what it was in 2019. So just looking at the horizontal axis now, we can see that many states had very few COVID-19 cases during the March to May shutdown period. The states with the highest COVID-19 levels were New York, New Jersey, Massachusetts, and Connecticut.
Can I just jump in and say, again, to be a provocateur, I might interpret that to say there were a lot of states that had a shutdown that kind of didn't need it.
Mm-hmm.
Which is to say, and I remember the debate in those days was, what are we doing? This is crazy. Why are we shutting everything down? And others saying, are you nuts? This is a pandemic. We're all going to die. And then there was these attempts to try to get so-called smart lockdowns. I remember in the Netherlands, they were trying to develop this as a model that, you'd monitor the incidence rate and then you'd have lockdowns and they'd sort of be variable. And, we've learned a lot, and I have not followed all this in the kind of detail that some of our colleagues have, so I'm not going to pretend to know a lot about this, but it is an interesting question, whether we couldn't have had a different way of doing this. But for our purposes, this is a natural experiment that's kind of interesting and illuminating.
Yeah. I think I'll just say, like, the goal at this point was to stop the spread of COVID, which obviously did not work through the rest of 2020. But yes, as an Australian, I can say a lot about full lockdowns across the country.
Yeah.
But we'll move on. So the state overuse rates all were lower than the 2019 levels. But the size of this decrease did vary across states. So New York, New Jersey, and Connecticut had some of the largest decrease in overuse rates. And these were the states with the highest COVID-19 incidence during this time.
And the decrease is shown by where they are on the y-axis, like
Correct.
how far below 1 they are. Yes.
Correct. So the other state that also had a large decrease was Wyoming, even though they had no COVID-19 cases, or very close to no cases during that time.
Yeah.
So the new results that are on the graph now, the blue points, again show the state procedure overuse rate ratios, but this time it's when the state had a high COVID-19 incidence. So there was a lot of variation in the state changes in overuse rates, and this did not correlate with the COVID-19 case rate in the state. So for example, Alaska had fewer COVID-19 cases than Nebraska did, but their procedure overuse rates was much lower.
Yeah. Well, actually, and what about all these states that are above 1? Is that saying they had more overuse than 2019?
By the actual number counts, yes. But when we look at a lot of these volumes in the states during these periods, the volumes are quite low. So we can't be totally certain whether or not it's greater.
I see. So these are, so this is, the volume is lower, but as an estimate, it may not be significantly different from the prior year.
Correct.
But the rate, but to be clear, the rate of overuse did not decline precipitously during these high COVID periods.
That's also true. Yeah.
Right.
Yeah.
Yeah.
I mean, that they didn't even go down to the level that Wyoming and Connecticut and New Jersey and New York were during when COVID rates were high.
Mm-hmm.
Right.
And
Well, yeah, and to amplify on my kind of prior thought experiment, if you were imagining quote unquote smart lockdowns, then you'd expect, and if that were truly properly implemented, then you'd sort of expect to see changes in volume that correlated with the incidence. In other words, the more to the right you go on this graph, the greater the incidence of COVID. So you'd expect to have much lower rates if that were true. So you'd expect a negative slope. Kind of, sort of, maybe we see that, but it's not powerful, that's for sure.
Yeah, no, there was no real linear correlation here in this plot.
Yeah.
Great. So here are our key takeaways from our third research question. During the shutdown period, we did see some of the greatest declines in overuse rates in those states with the highest COVID-19 burden. However, later in 2020, when the COVID-19 cases were actually much higher across the US than during the shutdown, there was no association between COVID-19 cases and decreasing overuse rates.
So
Yes.
just to boil this down, it took a shutdown to bring overuse rates down. That's kind of discouraging, I mean, it took a pandemic that we didn't understand at all and a shutdown to actually get hospitals and physicians, because I believe they're really driving the overuse rates more than, patient demand, to say, oh, we can't do this stuff. We gotta cut this out. I mean, does anybody else find that discouraging? This is an issue that we've all been thinking about and worrying about and talking about for a long time, more than a decade.
Well, look, let's be clear, it's a small coterie of researchers and mostly health policy people who are focused on this. The vast majority of, the sort of large medical academic hospital enterprises are taking care of patients and they're doing it the way they did it, and this is an issue, but it's not front and center, and it's not something that, has been, raised to the level at which they must address this or they must respond. So you kind of have to make the case that for this to become much more central to people's thinking, you'd need some other major thing to happen. And so in the case of the shutdown, it wasn't to do anything about overuse, it was something completely external. So I think, what we have to recognize is that here we are, pandemic, no vaccine, a lot of concerns. And in that context, it took really an administrative fiat to have this impact. So I think what we learn from that is that on our own, healthcare professionals, at least, using the current mechanisms of transmitting ideas and information and thinking about, rethinking culture and all those dimensions about, is more better? Is it always better? All those questions that we in the research community have been thinking and talking about for a decade, others have not. And so it's going to take more than awareness. It's going to take a lot more, and almost certainly some degree of policy, some degree of payment. And I think my own view is that really the most efficient way of getting at some of these changes is through sharing data peer-to-peer in an environment that is not punitive and not about anything other than doing the right thing. But even there, you have to create around that process enough sort of guardrails and even, if you will, safe space, some of which may be financial safe space, to be able to say, yeah, let's tackle this and let's figure out why all this practice variation exists and what can we do to get better. And then there's a lot more to say about it. But that, I think, is part of what we're seeing here, which is it's going to take a lot.
Yeah, I guess I'm a lot more pessimistic than you are, Vikas, about the power of positive persuasion. I think it's going to take some really draconian policy to really change this practice. I think that what we've seen in Canada and Australia, for example, with individual procedures, that when you stop paying for things, they stop happening. And so part of the problem, obviously, and we've been saying this, this is our mantra for a long time, fee for service is not the way to go. I was going to use a more pithy way of saying that, but fee for service is part of what drives this. It's the sort of individualization of, oh, do one more procedure, one more procedure, one more procedure. And that's not to say that every physician who does an unnecessary cath or an unnecessary hysterectomy is sitting there rubbing their hands together, but it is an unconscious and very powerful driver. So we have to change payment policy. And I think we have to change the way we pay physicians. We've said that a million times. One frustration with this research is we don't have access to, say, Kaiser data, which would be very, very interesting to be able to compare the fee-for-service world to the salaried physician world, but we don't have access yet to Medicare Advantage. When we do, I think that will be very interesting. And I'd love a sort of a retrospective, if there's a way to do that. And we don't have access yet to commercial data, and we should. It's a criminal offense that we don't have access to commercial data. And so people are asking this question all the time, and people can kind of hide behind, people who like the status quo can hide behind the fact that we can't say for sure this is true in the commercial side as well as the Medicare side. But so it's ridiculous that researchers don't have free and easy access to the commercial data to say, yes, this is also true in the under 65, or no, you're right, it's not true. But I think it's going to take some really, really big changes, more than sort of clinicians being incentivized or urged or, learning how to do the right thing. And
sure,
call me cynical.
Yeah, look, I'm not optimistic in that sense. I think this is a very steep hill to climb. But the idea that draconian measures will work, no, they're not going to work either necessarily. They may, wreck things, but by themselves they're not going to work, because at the end of the day, you really, to have a smoothly functioning system, you have to have people sort of bought into the whole Megillah. And I think, when I say peers, sharing data with peers, I've seen it work. It works, but it's not in isolation. Yes, you have to, just to be clear, when I've been involved in, globally budgeted kind of risk-bearing physician networks, where there is an incentive, but it's not the incentive for any individual encounter. It's not like the piecemeal, but the financial health of the whole enterprise depends on being judicious.
Right.
Even there, it doesn't mean all this stuff just goes away because people are homo economicus and they just calculate their economic interests. It doesn't work that way. You still need the data. You still need, culture change. You still need leadership. But without each of those, it ain't going to happen. It all has to happen together, including the payment changes.
Yeah.
And
sorry, excuse me, Vikas, go ahead.
Certain things, I agree, for certain things, just a diktat from the payer can work. Our colleague Adam Elshog, I think, has shown that slide for vitamin D, right?
Right.
The
Vitamin D
rates at
testing.
which people are testing vitamin D levels, and Kelsey, was it Australia or Canada? One of those two basically said, you know what? Once a year is enough.
It was Australia. It's a
And
very
boom,
sunny country.
It just changed. And
Rates
so for some things it's perfectly appropriate, but it has to be a scalpel, not, a bludgeon.
So we have a couple of questions that I just wanted that I wanted to bring up right now, because it's germane to this part of the discussion. And then we want to sort of talk a little bit about patient safety. So from Thomas Benzoni, we have, you noted that payer class didn't seem to influence these decisions. Does not payer class make a difference? What is the incidence of low value care in those who can't pay? So that's a very interesting question. And one way to look at that is look at Medicaid data, because you have lower rates for Medicaid patients, and the data are kind of all over the map. And I'm going to pull Kelsey and Vikas into this, but there's lots of overuse in the Medicaid population as well. It's not like that overuse goes away when the financial reward is less, as Vikas has said, that the financial piece of it is not everything. And that's absolutely true. So there's plenty of overuse in the Medicaid population. There's plenty of overuse among people who are poor, as well as the rich. It's not like the rich are the only ones who get stuff they don't need.
Yeah. So another question, which looks like it may be above my pay grade. How do you balance the empirical utility of a service with a patient's choice and autonomy, or the potential harm to well-being? For example, you suggest that patients could live with uterine prolapse, but other research has shown that it's correlated with negative behavioral health effects such as shame and loss of intimacy. Further, there's also many news reports in cases where patients are underdiagnosed or misdiagnosed because test procedures weren't performed or dismissed. How do you square that with your findings? So first of all, yes, underuse is absolutely a problem, which is why I get nervous with people who start talking about global budgeting as the silver bullet. It ain't the silver bullet. In fact, without a lot more care in the implementation, global budgets or Medicare Advantage, especially Medicare Advantage and for-profit with for-profit incentives, are almost, a formula for underdiagnosis and undertreatment. So I think that is an issue and it's a concern. Really, this gets to something that gets awfully philosophical, and therefore, I'm a little uneasy going there because it's sort of hand wavy. But at the end of the day, there's no substitute for the solid relationship between the clinician and the patient. Knowing each other, understanding preferences, understanding point of view, understanding the realities of the life of the person is part and parcel of this decision making. And so, the question of what is and isn't appropriate for many of these has to be passed through that prism. It's not an algorithm. What we're doing with these reports are we're trying to use claims data to get a sense of the direction and sense of the magnitude. But for any individual case, there's tons of nuance and there's a lot in the relationship that's really going to matter. So I don't think you create sort of this blanket statement that everybody blah, blah, blah should not get this or should get this. So for the question of uterine prolapse, I think all I was saying with that, I don't want to overinterpret, all I was really saying with that was that relative to a cancer diagnosis, in the face of a life-threatening pandemic, it's easy to see why that would be much more sensitive to, the opting for that would be much more sensitive. I'm not saying that these people were making a decision forever to never have surgery for their prolapse. I'm just saying that it was easier to defer, to delay. And that's true across the board. And the literature on this, and some Dartmouth work in Ontario, actually, I think is the one that comes to mind, shows that when people are really given some time to delay and rethink and think about it, the rates of surgery, whether it's orthopedic surgery or even surprisingly bypass surgery, in Ontario, go down, because after a while, many people adjust or adopt. The idea of what's needed or what's absolutely critical is fluid and can be fluid and depends on so many other variables. Sorry, I'm hogging.
So I want to reinforce two things that Vikas said. One, so when we do look at salaried group practices like the VA, it's not like there's no overuse in the VA. It's not as if global budgeting and salaried physicians wipes out all overuse. It absolutely is not a silver bullet. But for those who are going to say, oh yeah, and Kaiser doesn't let you do things and it underuses and the VA underuses, the data don't support that. There's sort of, there are problems within any payment model and any system, but you start to change the way people think about what they're doing a little bit when you change the payment model. But number two, the question of patient autonomy is really important, and the issue of how well patients are really informed about the trade-offs between their different treatment choices. Because remember, when you say elective, what that means is you have treatment choices. You have the choice of not getting treated. You often have a choice of getting surgical treatment. You have the choice of getting medical treatment. You have a choice of getting physical therapy. There's all kinds of choices, and patients do not understand the trade-offs between those choices because they're not very well informed. And it's not because they're stupid. It's not because they can't understand. It's because we don't have a practice of truly helping patients understand what those choices mean. And to me, that's what patient autonomy is. It's not, oh, well, here's you can have surgery or you can do medicine. You just decide. That's abandoning your patient. Truly having that relationship and truly understanding what the patient values for the clinician to understand what the patient values and for the patient to understand what they value and what the trade-offs are is how you make an informed decision. And we don't have very informed decisions in this country. I don't think any place really has fully informed decisions.
Yep. There's another question here. Is Medicare Advantage a policy solution whereby we give authority to an insurance company to determine whether
Great idea. Not.
Right. Well, so Medicare Advantage, my issue is, so I'm a big believer that if a large enough clinical group is taking financial risk and owns the problem, that they're incented in a different way, and that's not unhealthy. The problem I have with a Medicare Advantage model is not the setup of the finances, but the fact that it's typically run as a for-profit enterprise, so that a lot of the savings are not plowed back into the community, into schools, into housing, and any of that, or even for that matter, primary care. And so that whole model of reducing care with an profit incentive is quite problematic. At the level of implementation, as somebody who practiced for 30 years, it's insane to expect or want or hand over that kind of power to insurance companies or 1-800 no you can't. That just doesn't make sense to me. But almost like with managing the pandemic, I think we have to think in layered approaches. There's certain things, certain practices that are just insane. You shouldn't be doing this. Nobody should pay for this. Full stop. It's national. Other things that are much more gray areas where it's really up to the clinician, patient, and maybe a risk-bearing entity that says, the data is not clear. Okay, if you're going to do it, fine. We may set up an internal prior auth or utilization review amongst our peers in the local community. That's very different. And then finally, there's probably another layer that says nobody knows, and it's really counterproductive to patient autonomy to be, practicing this kind of medicine. So let them do what they want, right? So I think there are multiple layers for that. And the structure as it is, I don't think is way inadequate.
I think we have time for one half of one more question. And there's an interesting question here. How do the elite hospitals like those on the US News Honor Roll do in terms of overuse?
Well, what we have right now, or certainly for PCI, for example, coronary stents, the average was about 21%, but the range and variability was quite high. And
21% of what?
The number of the rate, the overuse rate. But some were as high as in the high 40s. So it's highly variable. And just to remind people, or those who don't know, we did a study last year that Kelsey led, in which we looked at what types of hospitals are associated with different propensities for overuse. And academic hospitals in general, which tend to be the hospitals that are honored in the US News Honor Rolls, they tend to do well. They tend to avoid overuse on average. But within that, there's a lot of variability, and that's what we see. There's more questions. I guess we could sneak in a few more.
Yeah.
Yeah, I was going to say so our study only went to 2020, but the COVID pandemic did not end in 2020. And I think in a lot of ways, 2021 was much worse, especially as we all waited to get our vaccines. So I really just want to say, I don't want to extrapolate our results to that period. I think hospitalizations were much higher then as well than it was in 2020.
Yep.
So we had another last question, quick question. What role do patient advocates play in helping reduce overuse? Well, the sad part is that most of the patient advocacy groups are highly funded by the pharmaceutical industry. And so they're actually, to some degree, driving overuse of medication. So that's a real problem, I think. They could have an important role to play in reducing overuse, but so many of them are not. They're really focused on cures, and the pharmaceutical industry is going to give us the cure. And there's only a few that have really started to ask the question, hey, are we sometimes getting things that we don't need, and what can we as patient advocates do about that? One of them, for example, is the National Breast Cancer Coalition, that has been quite vocal in the need to reduce unnecessary breast interventions and unnecessary mammography.
All right. Our time is up. Well, thank you all for joining us today, and a big, big thank you to you, Kelsey, for being on the panel. And remember, all of you, you can visit the website lownhospitalsindex.org to see our findings in detail. So along with this COVID research, we've also announced the top and bottom 50 hospitals for avoiding overuse, which will be part of the full 2022 Lown Hospital Index rankings, which we're going to be rolling out in late June. That'll be the launch of the full index and we'll name the most socially responsible hospitals in America.
Great. See you next time.
Thank you.